All right, guys. Well, thank y'all so much for coming. If y'all are cool with it, I sent a few questions out to go over. You guys, this is residency. In standard fashion, the third years are closer to the back and the interns are closer to the front. You are not allowed to recruit them before they graduate. But thank you guys so much for coming. I think anytime we hear about new models and opportunities for innovation and change in healthcare, we're excited to hear about it. And I think Dr. Rice came, was it almost 2 years ago? A year?
1 year.
Okay, all right. So if you guys don't mind, if you could, as we go down the line, just tell a brief story about how you guys came from, let's say, can we call it corporate medicine? Is that a safe bet? To a more direct primary care model. This one is.
Oh. It's just sitting up there.
Okay.
Oh, that was mine.
All right.
You're welcome to keep it.
Looks like a great family. Looks like a great family.
I don't like it.
Yeah. My kids, when they want a phone, I say it's just work. It's nothing.
Right.
All right. So maybe Dr. Rice, if you want to start.
Sure. Well, welcome everybody. We're here to talk to you guys about direct primary care, and there's a growing number of us getting involved. Some guys that have been involved longer than I have in the direct primary care movement, and that I learned from. And before I opened 4 years ago. My practice is called Pure Family Medicine, and I still practice pretty full spectrum family medicine. I still deliver babies. Thankfully for our OB hospitalist group, because they're my backup, being a solo practitioner out in the community, I don't have any built-in backup, but that's who I kind of lean on for that, but still get to do that part of my job, which I really love. And to answer your question about what kind of led me to direct primary care out of a more traditional insurance-based model, truthfully, it was a little bit of burnout. So I came back to Bryan College Station after residency and started working for St. Joseph Hospital System as a primary care doc in a very traditional clinic. I was very busy, had a very full patient panel. I was seeing, probably much like Chris, 25 to 30 patients a day, every day, just grinding my life away. And I have a bunch of kids, I have 6 kids, and all of that just sort of came to a tipping point about 5 years ago. And I just decided that I needed to do something different, or I wasn't going to be in medicine for very much longer. And so for me, I just started looking around at different models and different ways of still getting to practice medicine that felt a little bit more genuine and a little bit more patient-centered. I think we talk a lot about being patient-centered, but it didn't feel like it to me in practice. And so I ran across direct primary care. I started talking to a bunch of people online. I started talking to some people locally who were already doing it, and just jumped in 2020, which was a really inopportune time to make that decision. But I made the decision before the pandemic, and I just kept moving forward with it despite the pandemic, and it's worked out okay. We're coming up on 4 years, and as busy as I want to be.
I told Dr. Cook he could come down and say hi, but he needs to not change careers in the next few. Okay. So, yeah.
It is a trend, right? A lot of us have jumped ship.
Dr. Imperial.
So I'm Chris Imperial. My story is a little similar to Dr. Rice's. I was just too chicken to do it when she did. We were actually in the same group for years. And similar thing, you know, I felt like I could see things coming with the changes in healthcare and family medicine. And I felt like I could keep doing what I was doing until it either drove me crazy or started hurting my family. And it just got to the point to where I felt like when I was walking in to see a patient, I had my agenda that I had to get through first, as far as making sure I'm meeting metrics or checking the right boxes or things like that. And then I could then find out what the patient wanted. And when a good friend, one of my partners and I, we would talk every once in a while in the hallways. And when it got to be where we were thinking about retiring at 55, I knew I had to do something different. So it was either retiring or doing something different. And I'd heard about DPC, you know, probably even before Dr. Rice did, but I was, again, too chicken to jump when she did. And it took me about 8 years once I first learned about it, and just wasn't a good time for our family, but went ahead and learned about it, talked to a lot of people, picked a lot of brains, and to see what other people were doing. And so about a year ago, January, I opened my practice just across the street over there. And it's called Rooted Family Health. And you know, you always say once things work out well, you're just like, why didn't I do this sooner? But it was just timing. It was the right time, and things have worked out better than I could have imagined. And my wife says I'm happier, and I think she's happier now too. And so I don't deliver babies. I still feel like I practice medicine, family medicine, the same way I did before, except now I feel like I'm working for the patients and not working for a bureaucracy or insurance company, but I can actually give my patients my undivided attention. So.
My name is Joel Richards, and I have a company called Doc Healthcare. And my story, I actually did ER out of residency and really liked it. I never thought in a million years I'd have a business or do anything different. I really enjoyed it. But over time, it was frustrating to see patients' frustrations with the ER system specifically, with billing, and you don't have much control over that as a physician. You kind of you're just an employee. So you just have to go along with it, and you know, get calls from patients about their $2,000 strep throat bill from the ER, and you know, that's crazy. You know, that's ridiculous. And it's 5 minutes of my time and $1.50 strep test. And so I don't know. That was just frustrating that I could do nothing about it. And at that time, the ER specialty as a whole was going through a lot of changes with these pop-up, you know, ER standalone freestanding ERs were getting popular at the time, and a lot of them were interesting business practices, to say the least. So a couple that I worked at several different ones, including St. Joe's and some of the freestanding, and they just closed down just due to greed and mismanagement, and it was really frustrating to have a good group of physicians doing the right thing, and then they closed because the guy wanted to, you know, borrow $1 million from himself or whatever they were going to do. So that was it. The second one that I happened to be working at closed down in a year, and I said, forget it, I'm going to just do this. And I'd always kind of had an idea that maybe I'd put a cardboard sign on the end of my street saying, you need a doctor, I'll just come to your house. And my initial thought was I would just do what I did in the ER, you know, because most of it is not emergent. It's just, you know, strep throat, you know, rashes or whatever. And so that's kind of how it started. And I just started going to people's houses, and I wasn't necessarily trying to do DPC. I didn't even know what that was. I just wanted to do something different. And I figured I'd try this for a couple of weeks and see how it worked. And that was 7 years ago. So.
I'm John David Heiser. My practice is called MyMD BCS, and I guess I was in med school around 2008, 2009 when everyone was debating Obamacare, and so that got me thinking a lot about healthcare policy and also the future of medicine in this country. And since I was still in med school, I had time to think about, well, what do I want to do with my future? Which way do I want to go? What do I want it to look like? And the way I saw things going with Obamacare passing, I didn't think that it would necessarily fix what we needed fixing in primary care. I kind of saw things fragmenting towards a public option, but then also a parallel private option that would be cash-based and maybe insurance for catastrophic things. And so I knew, like, I would much rather be on the private side with having more control over how I care for my patients and that sort of thing. So I learned about DPC my third year of med school when I read an article in a magazine about Atlas MD. You may have heard of them. then got to my third year in residency where I was really trying to figure out, okay, what am I gonna do? Went to Direct Primary Care Summit, a conference on direct primary care, learned all about it, and I was like, this sounds perfect. This sounds like, doctors get control back to take care of their patients. They have a direct arrangement financially with their patients, so their patients have the power, and can purchase what they find valuable. So it was a great fit for me. So I actually went direct primary care right out of residency. At the time, nobody really knew what direct primary care was. If you polled the public, about 12% of people would recognize the term direct primary care or DPC. And about 50% of people at that time could tell you what concierge medicine was because of the television show Royal Pains. So a lot of the docs that were doing DPC at the time were marketing it as concierge medicine. So that's kind of what I did. I ended up purchasing a practice that had just opened, that was started by two doctors that started Caprock here. They initially started my practice, my MD-PCS, to be a concierge medicine practice, but shortly after realized they wanted to open freestanding ERs instead. So they pretty much sold me the business that they had just opened, and I ran it from there. So what we were delivering was a direct primary care price point, and didn't have all the frills that concierge medicine really had. So over time, as more people have heard of direct primary care, I've really taken off the concierge medicine marketing off the website and everything, and it's and calling it what it is, direct primary care. So anyway, I've been doing it for about 9 years now, 9.5 years.
I guess I'm the baby of the bunch because I've only been doing direct care for 2 years. Joel is my boss, full disclosure, so, but that won't influence any of the comments. I was, corporate medicine is the term that I use all the time. I was with Baylor Scott and White before it was Baylor Scott and White. I finished residency, started medical school late. I was 30 when I started. Graduated in '89, did my family medicine residency at JPS in Fort Worth, and finished residency and moved here. The goal, the plan, was to work for 2 or 3 years with Scott and White, where I had a salary. It was an established practice. I could learn what I needed to learn, get my feet wet, and then go out and start a practice somewhere. And there was another guy a year ahead of me in residency, a friend, and we had talked about this. That was our plan. And so he was at Scott and White here before me, and 30 years later, I was still there. So, great organization, merged with Baylor in 2013, and the corporatization really started, it was very palpable after that, and only got worse with time. So, I know what Dr. Rice meant when she said a little bit of burnout, because she doesn't mean a little bit of burnout. There was a lot of burnout, and there were, just putting in, I always said a good retirement job would be a 40-hour week, because you just see patients for 40 hours or so a week, and you put in 80 hours, feeling like there was always somebody looking over your shoulder, making sure you put the right ICD-10 codes, documented the right amount of time, checking all the boxes that others have alluded to. My situation was, I had known Joel a little bit before I left Scott and White, and just thought, what a cool deal. That would be so much fun. I just thought that would be the greatest thing. We'd get together for coffee, once a year for a couple of years. When the pandemic hit, and the point of the story is not, well, let me not step into it that way. A decision came about what I was going to do, how I was going to practice medicine, but more importantly, how I was going to make decisions about my own life. And so it came a time that burnout was high. I was looking at 30 years with the company and wanting to scale back a little bit. So it was just an easy transition for me to, instead of cutting back my hours, because the guys I worked with, at Scott and White that were going to 75% time, working 3.5 days a week or whatever, they were still working 70 hours a week. And I wasn't excited about that. So having talked with Joel, it was just real easy for me to leave the corporation, leave the firm, and do something that is more enjoyable. I feel like I'm practicing medicine in a way that's more true to what I've always wanted to do, and it's been the best thing of my life.
Yeah, thanks for those stories.
And I have a great boss.
Oh man, small corporation instead of big corporation.
Right.
No, I got you.
I just want to introduce Dr. Harrell also.
I'm an OBGYN physician, and I just joined Dr. Imperial's practice in October, so I'm brand new here at Learning also to hear from these physicians. I also worked for 20 years for Scott and White and had some of the same things going on as a specialist as you all described in primary care. I was 52 and thinking about when can I retire, and it was overwhelming, wanted more time with patients and less of a corporate environment. So I was thinking specialties were feeling the same, some of the same things.
Sure, makes a lot of sense. I was gonna ask, I have a few questions, and if we could just keep going down the line, and then when we get a little bit closer to the 4 o'clock hour, open it up for questions. So you guys will have to participate too. What has been like the single best thing about your transition into DPC? If we could start with you, Dr. Rice.
Yeah, I think if I had to really distill it down, it would be that and I feel like all of us have kind of said this in one way or another. For me, being able to practice in DPC really, really puts the patient back at the center of the equation. So it's not the insurance company, it's not a metric, it's not a corporation, it's not a hospital system saying you have to do this, you have to do that, you have to do this. There's an ethical obligation to practice good medicine. Yes, we all have that, right?
Sure.
But really, DPC is built on the doctor-patient relationship. And so it really puts that relationship back at the center of the interaction. And that honestly solved burnout for me. Like, yes, there's a lot more flexibility. Yes, you have more control over your schedule. Like, there's all these other things. But really, I went into medicine because I like taking care of people and because I have respect for humanity. And so that felt very stripped away when I was practicing in a corporate setting. And every interaction felt very sort of shallow and disingenuine. And so this really feels very authentic and like it puts the patient back at the center where they should be.
Great.
I know, I could just say ditto, because I really do feel like I'm doing what I want to do. I'm doing why I went to medical school and residency and taking care of patients. And so one thing I always, it kind of always has bothered me is when you hear people talk about doctors and burnout, it always made me feel like I was a weenie, like I couldn't do it, like I couldn't work hard or didn't want to work hard. You guys know what hard work is. You guys are working harder than you probably ever will right now. And so it's not that we don't want to work hard, but it's that in corporate medicine, we're having to do work that we were never trained to do. We never were trained to fill out all these forms or do all these other things that are now, the insurance companies and Medicare requiring us to do. And so it's pulling our time away from being able to take care of patients, what we love to do. And so that's the main thing. I feel like I can take care of patients.
Yeah, I think it's all about, relationships for me. It's, in the first 6 months, I had 100 times more deeper relationships with patients than I've had the whole time I ever was a physician. I mean, it's, and those are invaluable. I mean, I'll remember those for the rest of my life. And to me, that's worth it every day. I mean, just going to weddings and birthday parties and funerals and work project days at patients' houses just because you get to know them. That's invaluable. I mean, that's why we're here as other people. So.
That's great.
I'd say, yeah, autonomy and the ability to have control over my practice so that I can have happy patients. So ditto that. job. I definitely sleep a lot better at night, knowing that that I was able to take what I perceived, I was able to provide good care. In residency, the last time I was in corporate medicine, you know, you only have so much time per patient, and so I knew like there's questions I should be asking. I was trained to ask this question, but I can't because it's gonna open Pandora's box, and I'm already way behind, and so I didn't ask the question. And then that set in some moral injury, right? And like, I don't sleep good at night knowing I could have done a better job if I was in a better system. And so I sleep better at night, I have happier patients, I enjoy my job a lot, and I'm compensated well, so it's wonderful.
I think I feel like I've always put an emphasis on taking care of patients and taking the time. I have a reputation of always running behind. I feel the freedom to do that now. You know, we do, with Doc Healthcare, we go to patients' homes and we don't have an office. And that just literally brings patient care home. I mean, just, you know, when you're in their environment and they're relaxed, and I don't have people knocking on the door telling me I need to hurry or take a phone call or whatever. I've got the time to spend and practice a more, if you will, holistic type of healthcare, take care of the whole person. It just it's so much more rewarding, fulfilling for the patient, and
I just would like to tack onto that really quickly. One of the reasons that we all talk about having more time and being able to do a better job taking care of patients is because of the direct pay model. So whether it's pay per encounter, like some of Doc's patients, because y'all have both, right? Like you have membership options and you have pay per encounter options. Either way, by directly billing, you can create however much time you feel like is appropriate for the patient, and then it's valued at whatever you feel like it's valued for you. So if it's $150 for a house call, that's how much your time for that house call is, and the patient's willing to pay it. That payment structure is what allows us to have the time. Because the reason we didn't have time before was because in order to be profitable in an insurance-based system, you really have to see 25 or 30 patients a day. Like you can't pay your staff and keep the lights on and pay yourself in an insurance-based system without the volume. And so I feel like that is just worth noting, that like, yes, y'all, everyone wants to put the patient at the center, but there are things out of your control that keep you from being able to do that as well as you might like. And so for me, being able to change the payment model to a membership-based system, my shortest appointment is half an hour. Like absolute shortest appointment is half an hour, and most of them are quite a bit longer than that.
You know, I think anytime we ask a question about what's been the best thing, we have to ask the opposite one, which is what's been the most challenging thing or difficult thing as a switch from corporate medicine to direct primary care.
I get to start again. I was the first one to answer. Okay, great. I don't get to cheat off anybody. For me, right now, it's that I never get to put it down.
Yeah.
So I could probably do a better job of creating some boundaries, but I'm 4 years in, I'm incredibly busy. I probably have more patients enrolled than I should, but I'm bringing someone on this summer and I don't want to close enrollment because she's going to be starting and like, I don't want to lose the momentum. So right now, my phone never stops. I get texts late at night, I get texts on the weekends. And part of that's me and poor boundary setting. But part of it is the model and that sort of direct accessibility too, that patients are paying for a service and they expect to be able to contact you. I have a little spiel that I give patients about more urgent concerns versus less urgent concerns and which way to contact me, to, text or email or whatever. So that for me right now is the biggest challenge, to be honest, is just that I'm one person. I have one part-time staff person, and it's nonstop right now.
Yeah.
won't be that way forever. Some things are moving to make it not so, but for now, that's it.
Sure.
Now, I thought that would be my biggest complaint, because that's kind of, I think Wesley and I have pretty similar personalities. And so that was one fear that I had when it took me 8 years from when I first learned about DPC to pull the trigger. And for some reason, my patients haven't done that, at least not to that degree. For one thing, I did hire staff, so I have a nurse who answers my phones for me all through the day. And then in the evening, believe it or not, I hardly ever get phone calls. Maybe up until about 6 or something like that, and then they start calling around 8 in the morning. But usually patients don't bother me all that much. I've had one time, a patient called me, who was in the hospital, called me at 3 a.m., but that was the worst of it. Probably the thing that is the hardest for me right now is this model also kind of attracts people who are heavy utilizers of healthcare. So you guys know who they are, because they usually come to residency programs too.
So you're saying you're looking for referrals.
And so because they have that kind of access, they like this kind of program, and they're willing to pay even though most of them have insurance. And so that's probably the biggest challenge, just learning how to handle those patients. The good thing is I have more time. The other place where I had, by the time they got worked in and everything, probably 5 to 7 minutes to try to deal with their lifelong problem. And here, I have 30 minutes with each of them each time. They can come back tomorrow if they want. They can email me. And so my patients who are heavy utilizers at my old practice, I hardly ever see them here, and they're not coming in all the time. They're not bringing their long laundry list, and so it's a better system for those kinds of patients too. So.
Yeah, I think if you ask me in different times throughout this, it would be a different answer. But I think overwhelmingly for me, I am not a risk taker. I'm a pretty boring person. I'm probably the least likely to have business in this whole room, I guarantee you. So making that initial jump led to a lot of sleepless nights for sure. At first we were just a call on demand model. So you need someone to come to your house, they would call or text whatever they did at the time. So if I didn't see anybody, I didn't make any money. So that was stressful, because of family and kids, and I only had so much that I saved. But that was probably the hardest for me, just being a non-risk taker, doing this. It was rough sometimes.
Yeah, I mean, for me, it was the same, as far as learning to draw boundaries with neurotic patients. That was the hardest thing for me, but been slowly learning how to do that over the years, and it's been good, actually. So, just hard to do.
The advantage of being the last one in line, I have time to think about the answer. And what are the negatives? I can't think of any. I've had lots of time to think. I can't think of any. I would say in my previous practice, 15–20% of people really want to be healthy. They want to listen to what you have to say about how to eat healthy and get more sleep and just be healthier. And 80% of people just are coming in because they have to. Their insurance requires it. They can't get a refill until they come to see me. With this practice, people really want to be healthy. I mean, I get a lot more of that, so it's far more satisfying. Sorry, I'm not answering the question correctly.
It's okay.
I have yet to find a negative.
That's great.
And I'm not always that optimistic guy, so.
Yeah. One of the questions I've had for a while about DPC is, you guys are on a direct payment system. How do you guys interface with insurance and that form of care? You have a patient that needs a specialist care, or they get hospitalized, things like that. I would love to just hear from you guys about it.
So I think some of that might depend on your practice composition. My practice, about a third of my patients have commercial health insurance. They work for Texas A&M or some other corporation. They have really great health insurance, and they're members of my practice because of the accessibility. For those patients, they can use their insurance for whatever they want. I order labs, they can bill it to their insurance. I order an x-ray, it can be billed to insurance by the radiology department. They need to see a specialist, I just give them the phone number and have them make an appointment. Or I call and facilitate the appointment, but they can still bill their insurance for that. About a third of my patients are on some kind of alternative insurance, like a health share. They can submit receipts. I don't provide a super bill because my record keeping software doesn't include ICD-10 or CPT codes. So I use Atlas MD, you mentioned it earlier, that's the software that I've chosen to use because it was designed for direct primary care, and I really, really love pretty much every aspect of it. It integrates everything together, but it doesn't do that. So I know Joel does that better as far as providing like a super bill for patients to then turn around and submit to their, you know, health share or whatever for reimbursement. I can create one, it's just not very seamless. And then a third of my patients have nothing. They're completely cash pay, they have no insurance whatsoever. And I'm just filling a gap for them in healthcare where they wouldn't be seeing anybody because previous to me, their access to healthcare was to go to urgent care when they were desperate. And otherwise they didn't access healthcare really at all. And so that's been kind of interesting to observe. But just to answer the insurance question, it kind of depends on the patient and their specific situation.
Yeah, most of our patients are insured, either commercial or we actually, the way I do my pricing, it's advantageous for some of the older Medicare patients to see me. And so we have quite a few Medicare patients too. And so same thing, I can still send referrals or orders for things, and then their insurance will either the radiology or the lab will bill their insurance for services and things like that. We still do things like prior authorizations for radiology and medications. There are some DTC groups that won't. They just have decided they're not going to do prior auths for their patients, and the patients have to figure that out. But and I don't think there's any right or wrong way, but we decided to go ahead and do those prior auths, which isn't very fun.
Yeah, that sounds like a negative you're trying to hide.
That is a negative there, that is. But I have staff. Nancy was here a little while ago, and so she is used to, she was with me at my other office, and so she knows how to deal with those prior authorizations.
You know, I don't know the percentage breakdown. I would think probably most of ours don't have insurance, maybe, or it's maybe 50-50. I'm not sure totally. I think most of ours are cash. What we see is a lot of like small business owners or contractors who kind of work for themselves. But so I don't have to deal much with that. Honestly, it's easier than you think. Once you get out of the system, you realize it's pretty easy. I mean, there's a lot of stuff you can do without being in there, at least as from what I've found. In fact, the more you get out, the more you realize kind of how messed up everything is. And it's easy, you know, if we have a list of specialists that are great to work with, and if we just text, hey, I've got a patient with AFib, can I send them in? Sure, send them on. And it's about that easy. You know, we don't have to deal with face sheets or nothing like that because we don't have insurance, so we just send them the patient info and give them their phone number, and they call the patient and they come. Super.
So I have very little to do with my patient's insurance, the occasional prior authorization. Sometimes I'll do the PAs, sometimes I won't. It just depends on the medication and the situation. So oftentimes I'll check the GoodRx price, and if the GoodRx price is really low, I'm like, I'm not doing the PA, you can pay $15 out of pocket for this medication. And patients are like, oh, I didn't realize this medicine. Yeah, I'll be happy to pay it. That's pretty much it for insurance. As far as billing goes for my patients, I use the software. When a new patient establishes, I put their credit card number in the software, set the price, and it automatically charges their card once a month. And then technology's great, so it's super easy. Don't need anybody to do that for me, so it's pretty simple.
don't have anything to add. Joel's a businessman, so I don't deal with insurance at all. I will add one thing, and that is, I really have been surprised by the number of patients that I've followed for years, sometimes decades, at Baylor Scott and White, who have good insurance, as Dr. Rice alluded to, and they pay their insurance premiums, and they still pay to come see me.
Yeah, sometimes it ends up being cheaper to pay a monthly membership than you go to the doctor twice and you pay 2 co-pays, and that could be what the monthly membership fee would be, so, it depends on different people's situations.
Yeah. I've always wondered, is a panel size for a DPC physician very individualized? And I was just curious, we can't share information, insider secrets, but just curious, like, is there like a panel size that feels good? Does that vary between providers? I'd just be curious to hear your thoughts about that.
I think it's pretty individualized.
Mhm.
I think, so I'm part of a couple of just online Facebook groups for DPC docs, and this conversation comes up a lot, like what's the ideal panel size? And there are micro practices out there who wanna practice like 2 days a week, and they have a patient panel size of 150 patients, and they're perfectly content. Just a full disclosure, my patient panel size right now is about 670 people, and it's a lot for an individual. Like, I would not recommend this. Like, I thought I would stop at 500. There's been some reasons that I haven't done that. Not the least of which is that I have someone joining me in June, and I don't want to slow momentum for her sake. And so, at any rate, like, when I hit about 600, that felt very comfortable for me. Again, I don't really have any staff. I have a part-time nurse who does mostly things like prior auths and referrals and manages my phone. She answers the phone for me. And 600 felt very busy, but comfortable. 670 feels like a lot. So, put that out there.
Yeah, typically when you hear about practices, they're usually wanting a cap at, most people are saying cap at about 600. I don't know why that is, but it seems like that's what I'm always reading about.
Mm-hmm.
So we're at 500 right now, but again, I have staff, I have Nancy. So I feel like those micro practices, like how Dr. Rice has been doing it and Dr. David Heiser, I mean, it's hard to do that by yourself. I don't know how they did it for so long by themselves, so. Having Nancy and then Becky, my wife, is our office manager, and so that, I think that really helps, so that I can focus more on the medicine part and not medicine and business part, and not so much on the other.
Yeah, I mean, I think it's definitely individualized. I'm not gonna lie, I have no idea how many we have. I just don't know because we have I don't pay attention to it too much, and we have a lot of on-demand patients, so it's hard to differentiate we have a list that I could go look it up, but I don't follow the numbers, so to say,
Sure.
very closely. But it is definitely individualized. I mean, even like pediatrics can sometimes be a lot more maintenance, especially on the early years of life, than would a 30-year-old person. So I think even that makes a difference sometimes if you're doing, 4 well checks or 5 well checks a year, much less sick visits. That's going to take a lot more time than a 30-year-old who may come in once a year and text you for an ear infection or something.
Yeah.
So that makes a difference too.
Mm-hmm.
I'd say it comes down to how many services you want to be able to offer, or what you're offering each patient. Because if you're offering a ton of access, after hours and weekends access and all these things, all these additional add-on services, you're gonna have to take fewer patients, or you're gonna have to hire more staff to help you with that. So you can tailor your practice to what you wanna offer. And if you offer the bare minimum, if you didn't offer after hours access or weekends access, and you hired some staff to help you manage phone calls and sending in refills and things like that, and maybe you hired an RN to help do some triage on the phone and things like that, you could take a larger panel size, but you would probably charge less if you're offering less. So I've seen, concierge doctors that only take a panel of 100 patients, but they'll charge, $1,000 a month and they just have really upper class patients and they do really well. I've kind of found what I like to offer patients, what makes me happy, and I can cover my overhead, my expenses with 100 patients right now, and I have about 400 patients, and I'm very happy with that. And that I could take more. I think I could definitely get up to 600 if I wanted to. 800 would be pushing it. I probably need to hire some more staff to help with the little things around the office that I like to do myself. But I've stopped at 400 because I do a lot of side hustles as well that I enjoy and don't want to give those up. So, yeah, you can make it what you want.
Yeah.
I would say like most say 300 to 600, somewhere in that range. But Atlas MD, I think they take over 800 each over there. So
They have a pretty robust staff,
Yeah,
and they have, you know,
if
so I think a
you-
lot of it just
Starting to look a
depends.
bit corporate, you could
Yeah.
say.
Yeah, well,
I'm just kidding.
you can still do 30 to 60 minutes
Yeah.
face to face with the doctor,
Yeah.
and you could you can still see, you know,
Yeah.
6 people in a half day, and so 12 people in a day, and still give them 30 to 60 minutes a visit if you have enough staff to take care of all the other things that
Sure.
need to happen for a patient.
Yeah.
So
Right.
you could take on a pretty big panel if you have the support in your office.
Yeah.
But that just means more emails, more meetings, more HR stuff that you have to take care of and look after. And so I like to do everything kind of myself. I have 2 part-time employees. I like to hire pre-med students and pre-PA students from A&M. They work really hard. They work really cheap.
Just like residents.
I mean, they're like very motivated to do a really good job because they
want
definitely
that
want to
letter.
get a good letter out of it at school, and so and that's all I really need to have somebody. Actually, I brought one with me. Cade's in the back standing up, but he just got accepted to Texas Tech Med School. But he gets to do all the things I hate doing, so he's been awesome. But we've developed a good friendship over the years. So.
I was curious to see what Joel would say because I don't know. In fact, until you asked the question, I haven't even heard the words panel size for over 2 years, so. If my schedule's open, it's full.
There you go.
Speaking
Yes.
of panel size, can I bring up another question?
Mhm.
But I think this is a common question about DPCs and where we are in healthcare right now, talking about physician shortage. I mean, everyone's talking about how many family doctors are gonna be short in just, 10 years or something like that, and how DPC could worsen or improve that idea of a physician shortage. And of course, I'm a DPC practice, so my answer is gonna be swayed towards DPC. And I think it's beneficial. I think in the long run, now, if everyone does DPC today, obviously tomorrow there's gonna be a problem with lots of patients not having care. But in the long run, if we have more DPC practices, then people like me won't retire at 55, people like Jim won't retire, and I think we have more longevity of doctors. The other thing, we'll have more people going into medicine. If we could show that family practice could be something that you can enjoy and be happy about and live satisfied lives and things like that, then it won't be as hard to fill family practice slots. And so I think there are a lot of long-term advantages to DPC as far as fixing the physician shortage problem. But it is an argument. I agree that it is an argument about against DPC.
That's great. Well, I figured we have about 15 minutes left for formal end. Does anyone have any questions they want to ask?
Can I ask a question?
Taylor.
So I know you touched on, I know this is a touchy subject for everywhere, but money.
They're comfortable with direct questions because they're direct primary.
I don't know what I could ask, why isn't, I guess, everyone doing this? Because if I did the math right, you guys are making twice as much as a clinician.
Yeah, I think it's important for you guys to know about the money. I don't like talking about it, but yeah, I want doctors to go into direct primary care, and I hate, it sounds like a brag. Please don't take it that way. But my compensation is about 2 times what is average for Brazos County for a family medicine provider.
Right.
And so why aren't doctors doing it? I have no idea. I've tried to preach to everybody. I don't know if it's fear of going out and risking starting a business and maybe they don't know how to run a business or just, I really have no idea. Maybe you guys have some more insight on that, but I always see positives. Better lifestyle, better compensation, happier patients.
On the other side of that, I make less than I made at Baylor Scott and White considerably, but I have the advantage of being older. I've done this for over 30 years, and so I'm 68, and I can do this until I don't want Joel to hear this. I can until I'm 85. I mean, I can, because I have a great rapport with my patients. I feel like I'm effective, I'm accomplishing something, and I'm just having the funnest time in my life.
And I think you get to have control too of like how much time you want to put in. I have 6 kids and they're not old. My oldest is 20, but my youngest is 6. And so I have a lot of other obligations besides my full-time job. I'm the primary breadwinner for our household. My husband works in ministry, which pays like nothing almost. It's great work, but not paying the bills. And so I've chosen to like, my workday ends at 3 every day. I work 5 days a week, but my workday ends at 3, and I'm taking care of 600 plus patients, and making a very comfortable living for my household and paying for lots of colleges. So it's very doable. Financially, it's very doable. There is some overhead. Some of that depends on how you want your practice to be, right? Some of us run really, really lean. Some of us are not as lean, you know, but a house call practice doesn't have a huge ton of overhead. I have a pretty good sized clinic building, and so I pay rent and utilities, and my building's in a 100-year-old house, so it's not the most energy efficient thing ever, but I like the feel of it. So like, that was important to me, that this feeling accompany my clinic. And so it's just, you know, it's an overhead that I'm willing to undertake. I still practice OB, so my malpractice insurance is way more expensive than anybody else sitting up here. Cause that's just the nature of it. But again, I like doing that. It's fun for me. It's a reasonable source of income. It's not like a huge boon to my income because of the malpractice insurance, but I enjoy it. And so that's kind of the other piece, is like, you get to decide what's valuable to you. Is it the monetary income? Great, run a really lean practice and take home a lot of money. Is it other things? Then those other things have value for you. So.
I think Dr. Nutting is next. Sorry, then we'll get to
Sure.
Christina.
I would like to do this one day, and one of my questions is startup costs or startup process. Can you guys kind of go into that? Yeah. We're not about that, but just startup process and cost.
I can go into like right out of residency.
Yeah.
So when you start a new practice with no patients, mine started with 28 patients. So on day 1, when I showed up, there just wasn't a lot to do. So there was a lot of time for moonlighting. And with all the moonlighting I did while my practice was growing, I was making twice as much as I was making in residency. So it wasn't a difficult lifestyle shift. It was an improvement from residency. So that's what I did. I mean, so start moonlighting, start a job, save up money. I didn't start paying myself from my practice for 2 years, but that was kind of in the earlier days. I think a lot more people are aware of what DPC is now, and the doubling time of your practice is going to be a lot faster than it was for me. Also, I was unknown in this town because I didn't do residency here. I had no patients here, so the best way to grow is word of mouth in healthcare, I think, is to have your patients sell for you. So I noticed my doubling time was about 9 months. So it took a while to get going with 28 patients. So after 9 months, I had 60 patients, and then after another 9 months, I finally broke 100 patients. It took a while, and so I saw my co-residents who had been working careers for 2 years, and I felt like I was way behind. Like I had sacrificed a lot of lost income compared to them, but after it got going, made up for it and then some. So it's gonna be slower going in the beginning. You have to operate really lean, but with moonlighting, I mean, you'll probably do a lot better than you're doing in residency right now. So just keep your personal expenses low as well, you know.
I
Dr.
definitely agree with the moonlighting. I did ER, so I saved a couple of ER shifts a month at least to try to make up for it. So, I mean, you could probably do the same in urgent care or something. And residency is probably the best time to do it because you haven't made a ton. You don't have to, there's nothing you have to sacrifice. So, I mean, I agree. I mean, moonlighting to me helped bridge the gap, at least personally.
I did the same. So I left St. Joe's Clinic in early 2020, and I worked, it was the pandemic, so there was a lot of work for inpatient hospitalists. And so I worked as an inpatient hospitalist a few shifts a month while I was getting my practice off the ground. I did bring about 150 patients from my clinic practice into my DPC, so I opened my doors with 150 people pre-enrolled, which helped, meet the overhead, and then I was able to stop moonlighting after, so I opened in July of 2020, I worked my last inpatient hospitalist shift in December of 2020, so 6 months. And part of that was just, again, I have a lot of people that depend on my income, and so I needed it to kind of stay pretty much the same as what it had been when I was working in the clinic.
Do you need like 20,000 or 40,000 startup, or not even that much?
I think it depends on what you want to offer.
Okay.
I really do, because I think like if I had, so the things I had to pay for were a space, malpractice insurance, supplies, just like the basic things, furniture and whatnot that were gonna go in my space, and then like Band-Aids and stuff, just like the
Well,
normal
and I'll
stuff.
just kick in there, cause we just opened up a year ago, and it was probably $150,000 that we got a loan for,
We-
to start up,
Oh,
yes.
But if what's different was we did a huge remodel on that building.
We did.
Okay.
And so
Okay.
that was
And did you buy the building?
2/3.
No.
We just
Yeah.
remodeled it,
Oh.
but that was 2/3 of that was the remodeling.
I think
At
I'm
least.
Yeah, cause you go
Maybe
there.
not quite, maybe not quite 2/3, but I mean, you gotta bank for that. There's also, because there are so many DPCs, there are people looking for people to join their practice.
Sounds very individualized.
Mhm.
And asking some time, Dr. Casedio.
Could you speak, Dr. Rice, a little bit to how you incorporate OB into your practice? Because
Yep.
DPC makes a lot of sense, like from the primary care
Yep.
sense, but as far as like, because you're having to coordinate with like hospitals
For
and
sure.
villages and Medicare, and then I guess, Dr. McCullough, you're integrating OBGYN into your practice, I don't know.
Yeah, so just really quickly, it's kind of two buckets for me. So I'm credentialed at St. Joseph, I've always been credentialed at St. Joseph, and I've just kept that up. So that wasn't like a new thing for me, I've delivered babies in this setting since 2008. So it was more of a continuation, but yeah, I just kept my hospital privileges. That credentialing process is the same regardless of whether you work for the hospital system or whether you work independently. So I go through the medical staff office, I renew my privileges every 2 years, I have to have a certain volume for that, it's not very high, it's like 24 deliveries a year. And from like how I run it in my practice, OB patients are sort of a separate bucket from DPC patients. So if I have a patient who's already a member and they become pregnant, I charge them $2,500 for their prenatal care and their delivery. It doesn't include hospital charges, that gets billed to their insurance if they have it, or to their health share, or to Medicaid if they have Medicaid. I don't touch that. I don't touch hospital billing. I'm very upfront with them about that at the beginning. I'm like, this is between you and the hospital. Here's where I deliver. If it's a good fit for you, great. If it's not, let me help you find another provider. Like, it's fine. So the $2,500 is for members, so they're paying me a monthly membership fee to be a part of the practice, and then they're paying me $2,500 for all of their prenatal visits and any ultrasounds I do in my office and my attendance at delivery. I do have a bucket of patients who are non-member OB only patients, meaning they weren't a member before they got pregnant. They're only coming to see me for OB care. And so for those, I charge $3,500. It all comes out basically the same. If you do 10 months of membership plus 2,500 versus 3, it's all basically the same. Those patients can take that $3,500 invoice and it's got a CPT code and an ICD-10 code on it. They can turn around and submit it to their insurance and get reimbursed, or submit it to their health share and get reimbursed, and a lot of them do that. So that's how I do that. So it's really kind of its own little bucket of charging, of billing, and of enrollment. Because the ones that aren't already members and don't necessarily want to stay members, let's say that they love Dr. Sterling and want him to see their baby, they're just gonna see me for their pregnancy, then I'm gonna just happily send them right back to Dr. Sterling with their newborn. And their involvement with me will end when their postpartum visit happens.
I think Dr. Dwan, I think I saw your hand up.
Yeah, I was wondering, like, how did you get your initial, like, 28 patients? Did they, like, follow you from resident coming over, or, like, how did that start?
Yeah, for my 28 patients were recruited by the 2 doctors that started my practice. They actually ran it for 3 months, and they did some marketing. They also, as ER doctors, they were able to self-refer, so they were still doing ER shifts. And when they would meet patients that didn't have a primary care doctor, like, hey, by the way, I can take care of you after this ER visit. So they were kind of doing some recruiting there, but. So yeah, I think word of mouth is the best way to market, and it's completely free. But the second best, Joel knows probably a lot more about marketing than I do. Has tried different things, but I would say online marketing, like Facebook ads and things like that. Having a good website, spending money on SEO, so that when people Google DPC Bryan College Station, you come up number 1, number 2, number 3, and then the phone will start ringing. But also just pounding a lot of pavement. So in your free time, getting involved with Rotary clubs, getting involved with Chamber of Commerce, and meeting other entrepreneurs. I've met business people through the Chamber of Commerce that signed up all their employees with me. And so, there's a lot of ways of doing it. Just pounding pavement, networking, meeting people. I would not do print marketing. I didn't get any patients from print marketing. But there's a lot of markets that's worthless.
Last question, we're getting close to 4. Y'all are the last 2, for real. Afterwards, y'all can chat with I want to respect the 4 to 5 wellness.
This is like a urban/semi-urban setting. I don't know how this would work in a rural or semi-rural setting. Do you feel like the patients there that either don't have insurance or are underinsured would do well or not well with this model? Or have you seen that work out?
So again, this is just secondhand from some of the online groups that I'm a part of, but there are definitely practices in rural areas that are doing great. You may have to adjust your price point to the rural market, right? So if you're in a very rural sort of blue collar setting and patients aren't gonna pay $90 a month to be your patient, maybe you set your price point at $70 a month and get patients in the door that way. I think that all of us believe that there is value in direct primary care, and our patients would corroborate that, right? They would all say, we're paying a monthly fee because we find value in what you're offering. And I don't think that changes based on the setting. I think that there are people in a rural setting who will find value in what you're offering. It might look a little different than the way our practices look here.
Ultimately, so my experience was starting here in Bryan College Station that some of the other docs that were doing DPC in the smaller towns were growing faster than I was, and I was wondering, how can this be? They have fewer population, smaller population, but actually what drives people to DPC is lack of access to care. Because when there's a lack of access to care, then having access is more valuable to you. And so when you're in a small town, every small town's gonna have 400 people within a 30-mile drive. So you could pretty much do DPC anywhere, trust me. And in the rural areas, there's the access to care is atrocious. And so they would love to have DPC. So it would work in a small town, absolutely.
I've got patients that come in from Lexington and Giddings and Caldwell and the surrounding more rural communities here. So if somebody was closer to them doing the same thing, I have no doubt that they would get patients in the door.
Wonderful. We'll have one last question from Dr. Larson, and then if our panelists are comfortable, if you guys have any other questions, track them down. I've been very grateful you guys have come. So, your question?
So kind of similar to the last one, but we have a lot of patients in this clinic that are Spanish speaking, low socioeconomic status, and I think this model is amazing, but I just have a hard time thinking that some of them would be able to afford that, and we have, you know, like the sliding scale fee and things like that. So do you see any sort of like solution to that, or ability to practice this way, but also like catering to that population?
I think if it's something you feel called to, you can figure out a way to make it work. And what I mean by that is there are practices who see patients on a sliding scale that's income based, right? I haven't done that because I wanted to keep things incredibly simple for my own self to manage, right? But you could absolutely set up your fee schedule on a sliding scale. You could make it part of your business model that, you know, hey, if you want to pay your monthly fee, but then also sponsor someone who can't afford it, that's an option. And you can have other patients pay a percentage towards sponsoring someone else so they can basically access care for free. You know, there are a couple of counseling practices here locally that do that, where 10% of everybody's fee goes towards scholarshiping patients who can't afford it. So if you can imagine it and it's a value, like it's important to you, you can make it happen in DPC.
I mean, we can't do free, but, you know, we have patients that come in once at the beginning of the month, they drive in, they're waiting at our door with their $80 in cash or their check for 2 months or something like that, and they just come in and pay because they want the attention, they want the accessibility, they want the time. I mean, they really want this kind of care, so.
Yeah, you would be surprised the people who come and are willing to pay for the care that you wouldn't anticipate because they value someone listening to them and caring for them. And so it is not cost prohibitive for a lot of the population. You would be very surprised.
One thing to think about when I moved on to Ross is once you get out of the system, I mean, you can't change the price. You have no control over what people are charged. You control everything. So I don't take Medicare. I can charge whatever. It doesn't matter if I charge less than Medicare. I don't take Medicare. So I don't take any. And so all of my colleagues that I work with, they all have free reign to not charge it. So if you go into a place like that, hey, there's no charge. I mean, you have that freedom, which is one of the beauty. I love that.
Mhm.
You know, you can give discount to vet, whatever you wanted to do.
Yep.
You have control. That's one of the
You can
awesome
provide,
things.
you can provide free care.
Yes, you do whatever you
Oh,
want.
totally.
You can provide free care.
Totally.
And, to some patients, obviously.
Yeah.
But anyone who can afford cell phone can't afford direct primary care. No, honestly, it's not that expensive. And, if you think about total healthcare costs as a pie, in a conventional practice, you know, 5%, you know, in an insurance-based world, about 5% of that pie is spent on your primary care physician. The other 95% is on medications, hospitalizations, imaging, labs, surgeries, all those things. In direct primary care, about 10% of that pie goes to your physician. But the cost savings comes from shrinking the entire size of the pie by about 20 to 30%. So you actually do save your patients money by charging them cash and giving them better access to care.
Well, if we could get a round of applause for our panelists. Thank you guys so much. Really appreciate it. I know you guys are all busy clearly with big patient panels and a lot of texts and all that stuff. So thank y'all for coming. Really appreciate it. Hopefully this will be a regular event. If you guys want to hang out, I'm sure you'll have a few. All right.
I'll be too. I mean, you don't have to opt out, but I'm opted out.